Namaskar and a very warm welcome to all our viewers. Today is Young India Intensivist webinar number 359, and it's a great privilege and honor to welcome Professor Hernandez sir to the webinar, who will be giving this talk. It's an international faculty webinar. So the topic today is capillary refill time, physiology, applications, and future. And this concept has been developed by Professor Glenn Hernandez sir. I'm extremely proud to say that he'll be speaking on it. And he, as you all know, is the principal investigator of the Andromeda Shock 1 and the very recently published in JAMA Shock 2 trial. Sir is professor at Pontifical Catholic University of Chile, Santiago, and he's also the coordinator of the famous Latin American Intensive Care Networks Living. So with that, I hand you over to you, sir. Thank you very much for doing this. It's indeed a great honor and privilege for all of us.
Thank you very much for this invitation, which is, of course, it's an honor for me. I slightly changed the title of the presentation to Capillary Refill Time and Personalized Hemodynamic Resuscitation, which is more, let's say, accurate for the what I am going to talk about. Some physiological background. I will speak about septic shock resuscitation, not other contexts. The art of resuscitation is to couple macro-hemodynamics to microcirculation. This is the key. For that, you assess and you manipulate cardiac output and its determinants and mean arterial pressure. Cardiac output is the main determinant, of course, of oxygen transport, and mean arterial pressure is the perfusion pressure. And you can easily assess cardiac output now with less and less and non-invasive devices, and echo, and map, of course, with an arterial line and even non-invasively. You can manipulate this with fluids, vasoactive drugs, etc., just to push fluids to the destiny, which is the cells around the economy, the mitochondria everywhere, etc. In a shock state, of course, the disease in a septic shock is there. You have to push fluids across the distribution, regional distribution, the microcirculation of different territories, which is very heterogeneous, and the cells of everywhere. And here is the paradox, because you can easily assess the macro-hemodynamics, let's say, but the microcirculation only very poorly, only with surrogates of, let's say, mitochondrial function, surrogates of tissue perfusion, etc., as we will see. And you cannot assess the distribution process. You cannot assess the microcirculatory flow except in research context. And this is not manipulable. So this is like a faith-based medicine. You manipulate the macro, but you hope that it gets to the cells around. So this is what, in essence, is the problem. And of course, we always thought as let's say the resuscitation theater as a forward flow from the heart, the arterial side, to arrive to the microcirculation. However, this essentially, this is not that way. This is a total cycle where you have the microcirculation at one end, of course. You have the macro-hemodynamic, which you manipulate. But before the precapillary, what we could call the precapillary sphincters, and the gate to the microcirculation, you have the micro-hemodynamic domain where we can physiologically assess here the critical closing pressure, vascular waterfall, the mean systemic filling pressure, the waterfall, which is the driving forces for the microcirculation. We do not assess this normally. And then the flow has to return to the heart. And this is the role of the venous side, which was not taken into account until some time ago, some time ago. And this is can be very, let's say, jeopardized by venous congestion. Venous congestion can indeed impair perfusion in the microcirculation. Even if you have normal forward flow in the arterial side, the venous side is also very important. Sometimes you treat venous congestion and you get reperfusion of the microcirculation. This is a big problem here. And it affects this issue that is micro to microcirculatory coupling. And since these abnormalities assessed initially by Professor Caninci in Netherlands with video microscopy under the tongue, sublingual microcirculation, he described several types of microcirculatory impairment, derangements in septic shock, that many of these are related to congestion, are iatrogenic. So this is a big problem when you speak about reperfusion, about restoring tissue perfusion. And a more, let's say, broader problem in resuscitation is the extreme heterogeneity of critically ill patients. There is not one patient equal, similar to another one. It's very heterogeneous, as you may know. And we also know that resuscitation has a dark side. Resuscitation can kill via fluid overload, which impairs organ function and increase mortality, and also lung, kidneys are affected, essentially microcirculation, the liver also, and also excessive doses of vasoactive drugs, we can produce excessive vasoconstriction, can induce injury to the heart, etc. We are heterogeneous. Resuscitation can kill. So we have to be gentle. So the art of personalized resuscitation is to couple via gentle, precise, physiologically driven interventions, the macro-hemodynamics, to restore tissue perfusion as fast as possible, but without crossing the barrier of over-resuscitation. This is what we have to do. When we conclude at the bedside that reperfusion has been achieved, we have to stop this active resuscitation process to prevent over-resuscitation. We could ask ourselves if it is possible to achieve perfusion without congestion in septic shock, where many background pathophysiological derangement predispose make a patient prone to go to congestion. In the past, 30 years ago, Professor Shoemaker, Denisegwa, etc., in the early years of protocolized resuscitation, they proposed that maybe getting a supranormal microcirculation with cardiac index of 4.5, etc., could push reperfusion via a supranormal flow. And this could get to the tissues. For this, they use huge toxic amounts of fluids and vasoactive drugs, dobutamine especially. And what they did achieve at that time, in the 90s, late 80s and 90s, was congestion without perfusion. And then they killed many people probably about this, and this was fortunately abandoned in the 2000s. And then there came the famous study by Rivers in 2001, where it got a lot of attention, and we got excited. I remember when I read this paper the first time 25 years ago, because it was the first protocol that included one perfusion-related variable, central venous O2 saturation, as a marker of the DO2-VO2 relationship in the superior vena cava, and this was great. However, the big problem of this algorithm was it included some wrong physiological concepts. For example, to increase artificially CVP to the range of 8 to 12 to promote with fluids, to promote a better perfusion and better cardiac output. This is totally anti-physiological. Of course, a lot of transfusion, which are the threshold, are absolutely unacceptable, and a lot of fluids. So he got perfusion, but with congestion, and this explained the high mortality, although he demonstrated that in the intervention group, there was a huge mortality benefit. But this was not a equilibrated protocol. And this is what happens when we do not include physiology in our resuscitation strategies. This happens when we use the one-size-fits-all strategy. This is an example from the Surviving Sepsis campaign, which still proposes 30 mL per kilo for all patients when they arrive to the emergency department in 1 to 3 hours. But this is antiphysiological because maybe a young patient with peritonitis is with heavy hypovolemia, absolute hypovolemia, added to the relative hypovolemia of a decrease in venous return due to the venous vasodilation, and compared to an old patient with community acquired pneumonia with diastolic cardiac dysfunction, where if you give 30 mL per kilo for peritonitis, young patient, you will probably be short. If you give 30 mL per kilo to an old patient with this condition, you maybe push this patient to the ventilator, induce pulmonary edema, etc. And this probably has happened in hundreds, maybe thousands of people around the world that follow this recommendation. So, and this is a basic problem here, because if you follow the classic RCT from internal medicine approach to try to research this and to try to get responses about this, forgetting the extreme heterogeneity of septic shock patients, then you will come up with this sort of nasty studies like liberal versus restrictive fluids in the ICU, where patients just, you flip a coin and say to patients that are totally prone to get fluid overload, they are by chance they got the liberal fluids, and patient that is extremely hypovolemic gets the restrictive. I mean, just a coin without considering physiology. The same with high versus low macro, etc. This is not a response to what we need to get responses in critical care. And there are many factors that make that I'm highlighting in this slide some reasons about which designing studies is very complicated in septic shock because of the changes, different comorbidities, the source, the fluid tolerance concept, which is very important, hemodynamic phenotypes, the hemodynamic coherence concept, and others. So it is not easy. We acknowledge that it is not easy to design studies on this. But there is a relative and strong and getting stronger consensus, I would say, among people that, as me, we work in septic shock resuscitation, that we have to go for personalization of the hemodynamic management. It's not easy. We have tried this in the Andromeda studies, as I will say, but this includes a lot of, let's say, measures that are reviewed in this very, very nice paper a couple of years ago that I strongly recommend for young people to review if they have not yet. So it is possible to achieve perfusion without congestion. For us, the only way is personalized resuscitation to harmonize perfusion with congestion. Get rapid, gentle reperfusion, minimizing at the same time the risk of congestion. This is what we promote. And this is what we have done and try to do in the Andromeda studies, both the original Andromeda study published in 2019 in JAMA and the recent one, Andromeda 2, in October in the same JAMA paper. And I think that there are two things that characterize the Andromeda shock, and more will come. Of course, we have Andromeda Pegasus, by the way, and others. It's a family of studies, and it's a research network also. It's the beauty of simplicity. This is characteristic of the Andromeda studies, the beauty of simplicity, and also the application of strong physiological principles at the bedside with simple tools, without expensive equipment, etc. We have to assess, and this is from Michael Pinsky, assess circulatory effectiveness. I remember the first slide where I said the complexity of assessing the perfusion variables representing the microcirculation being restored, the flow, let's say. And there are several variables that have been used as surrogates, SpO2, PCO2 gap, lactate, etc. Each one of them has problems. If you want to, we have many free articles where we discuss at length all this, if you want to follow this lecture. But I will stand with peripheral perfusion. Peripheral perfusion has a long story, but in the modern times, the most important study in the 70s, let's say, in the 60s, sorry, was from Professor Max Arriwal, which is the father of shock. In this paper, nice paper in Circulation, 1969, he showed that the temperature of the big two was as a strong prognostic marker than lactate, disclosing the relevance of peripheral perfusion. You can monitor peripheral perfusion by different, let's say, variables. The Mottrin score, of course, is very important. The gradient, the temperature gradient, but I will just restrain myself speaking about capillary refill time, which is what we assessed in our Andromeda studies. It's important, capillary refill time or peripheral perfusion in general, because it's a long, extensive, physiologically relevant, remember the thermoregulation territory, that is under sympathetic control, essentially, as a difference with other territories that have also metabolic control and autoregulation. Here is the adrenergic control. So, if you get a cold, clammy skin during initial circulatory dysfunction, this may caused by an increase in adrenergic tone, redistributing fluid flow away from the skin to other territories. It represents a fall in microcirculatory flow, of course, the microcirculation of the hands, the skin. And also, it can signal the reperfusion process in real time. Imagine, you have a patient not yet resuscitated and has a cold, clammy skin, mottling, and let's say, very prolonged capillary refill time. And then you push fluids, you resuscitate, and a couple of hours later, you have normal disappearance of mottling, let's say, and normalization of capillary refill time. What you are looking at is essentially a reperfusion in real time. So you can see this in a costless way, universally available at the bedside, and you can say, okay, I got reperfusion. And from the epidemiological point of view or perspective, we have a lot of studies that finally demonstrated that there is at least 20% of difference in mortality of patients that rapidly normalized peripheral perfusion compared to those who did not. So it's very important. I will skip that one. And also, the perfusion of the skin, obviously, from a physiological point of view, is related to the perfusion, for example, of the hepatosplanchnic region, the kidneys, etc., the liver, because the same neurohumoral response that takes flow away from the skin takes flow away from the hepatosplanchnic region during shock to redistribute it to the active muscles, the heart, and the brain. And this was nicely demonstrated in this study by Brunauer with a Doppler of 4 major intra-abdominal arteries in parallel with assessment of capillary refill time and mottling, etc. And what we can conclude from this study is that if you have a rapid normalization of peripheral perfusion, you have high probabilities that the hepatosplanchnic perfusion will also be restored shortly after, because it's a little bit more complex. They will follow the same trend, meaning that the neurohumoral response is retiring. But the inverse is totally true, 100%. 100% in the sense that if you get a cold, clammy skin that does not recover, this is impossible that the hepatosplanchnic region recovers, which you cannot see, of course, it's a black box. And there are some strong, I would say, physiological data supporting that you can stop resuscitation with a normal CRT safely. You have epidemiological data, physiological data, 2 major RCTs now, and you can be confident. For example, in this small physiological study, we demonstrated that the CRT group here patient that had a normal CRT had also a normal SpO2, normal delta CO2, PCO2, normal hypoxia markers like lactate pyruvate, normal muscle oxygen saturation with NIRS, normal hepatosplanchnic flow, non-invasively assessed by the plasma disappearance rate of indocyanine green, normal, and the microcirculatory flow index by microscopy, video microscopy, and the microscopy under the tongue, normal. So you can be pretty confident that if you have a normal CRT, you have also a normal, profound perfusion of these organs. This is a pivotal, a key study before Andromeda 1. In this study published in 2014, if I remember well, we got a cohort of septic shock patients admitted very early in the intensive care unit, and they were resuscitated. And then we assessed different perfusion parameters over time, lactate, SpO2, PCO2, the gap, CRT, SO2 with NIRS, and these variables are microcirculation under the tongue. The columns represent normalization of these parameters in the patients. And after 1 year and a half, approximately, we took only survivors. These are survivors to learn the relevance of these changes. And you see that variables that we named flow-sensitive parameters, like CRT, 80% of the patient at least had, or 85 had normal CRT at 2 hours, compared to 50% only of patients with lactate had normal lactate at 24 hours. This means that depending on the variable that you select to stop resuscitation, you would have stopped in these survivors resuscitation, fluids, etc., at 85% in 85% of the patient at 2 hours compared to only 50 at 24 hours. So, of course, using lactate can be much more prone to over-resuscitation, etc. This was a fundamental study for us. To assess capillary refill time, it's very important that you use a standardized technique to decrease inter-rater reliability or improve inter-rater reliability. For example, we use this microscope glass slide. We compress the oval of the index finger here, and until it completely blanches. I will start again. We start, and then we compress until you see a total blanching. And then with the stopwatch, we count 10 seconds. After 10 seconds, okay, this is to equalize pressure between physicians with different strength and muscles. And after 10 seconds, you release, and then you count with the stopwatch the seconds with 1 decimal that it takes to rewind or reperfuse let's say the ventral part of the index finger. And this is 3.0, the normal value. You see, it is being standardized with a stopwatch and a microscope cycle. This is what we use in Andromeda, and it's very nice. And when you, let's say, you assess the knee, you can assess also CRT in the knee or in the index. They show a pretty nice correlation. And the inter-rater reliability is 80, 95%, etc. O sea, being, you see, strongly acceptable, I would say. And when you use a standardized way, you can, of course, get a standardized, reliable assessment between observers. In the Andromeda Shock 1, we compared this CRT targeted strategy with lactate. This is a very well-known study from 2019. And you probably remember that we got a very strong difference in mortality that was not statistically significant, almost, but the world considered it as positive, and we had a very highly significant differences in recovery of organ dysfunction, in resuscitative intervention, etc. And the superiority of CRT targeted strategy was confirmed by the Andromeda by a posterior, let's say 1 year later, we published in Blue Journal a Bayesian reanalysis of the trial. The three main, the key aspects of Andromeda 1 were the use of CRT as a target for reasons I gave already, the systematic assessment of fluid responsiveness, I will speak about this shortly later, and the concept of acute ecodynamic test, I will speak also later about this. But there is something very interesting and funny, a little bit funny, I would say, that when we designed it and conducted Andromeda Shock, the original study, the one, we had no clue about what CRT was. No clue. I mean, what is CRT? We could not have responded this question. But very importantly, we know now that is related to flow and to the microcirculatory coupling, to flow. For example, in this study, it is very interesting that assessing capillary refill time every 2 minutes after a fluid challenge, in this study by Hafid Al-Rafelia in Saint Antoine Hospital in Paris, he found that 6 of 29 patients did not respond. These patients were probably uncoupled between the macro and the microcirculation compared to the responders that tended to normalize CRT. And the important thing here was that at 10 minutes, there was a significant improvement in capillary refill time. Very fast. You give fluids, very fast response. And this, we have been working with Hafid and a group in Colombia, the French, Colombia, and Chilean. We have been working together with laser Doppler, and we clearly demonstrated, as this study shows, that there is a relation between capillary refill time and skin blood flow, assessed by laser Doppler. Here you see when the capillary refill time is normal, you see there is a normal, let's say, skin blood flow. And when you decrease capillary refill time, or you increase capillary refill time, you have a sharp decrease in objective skin blood flow irrespective of patient in norepinephrine or without, or in sepsis or no sepsis in the ICU. So clearly there is a relation with flow. And we demonstrated this also in this study where we compared healthy volunteers, their resting, let's say, skin blood flow in arbitrary perfusion units with laser Doppler. They had the same APU than patients with normal CRT and septic shock, and much higher than patients with septic shock and abnormal CRT. So there is doubtlessly, there is a relation with flow. And here is also in perfusion units here, at the knee side, where using jontophoresis with acetylcholine, Hafid showed that there was a very nice perfusion in patients with sepsis without shock, worse in patients with septic shock survival, and very low perfusion units in the knee with this in septic shock non-survivors. In the same, this the modeling score is also related to flow. You have no modeling score, you have a nice perfusion here by laser Doppler in the knee at this time, compared to almost negligible in patients with modeling stage 5. But this is Gustavo Espino, one of the genius of all these projects, a PI also of Andromeda studies, where we assessing more in-depth microvascular reactivity as putting the patients or applying, let's say, a vascular occlusion test to this patient. You see that when you apply a vascular occlusion test, this means that you put in the arm, in the forearm, let's say, a device that rapidly you inflate the device and you get mean arterial pressure 50 millimeters over the baseline systolic blood pressure, and the flow of the extremity decreases to almost zero. It's an ischemic challenge for 3 minutes. And then you release, and then you see the recovery phase of in this case, of nerves and the tenar eminence. With this, you can have an overshoot here, but we can do the same, not with nerves, but with laser Doppler. We produce this both challenge, decreasing flow to almost zero. And then you see that the recovery of, after you release the compression, the recovery of capillary refill time is very, very, very nice and and better in patients that will survive. And also this can be seen by a thermal challenge. But what Gustavo has done in Colombia is that he has further developed this lateral Doppler signal under the vascular occlusion test that is very nice. And you see ischemia here, the flow, and there is reperfusion. And then he got, let's say, he can decompose this, let's say, laser Doppler signal after the vascular occlusion test with very complicated techniques derived from the Fourier equation and other things that I don't understand very well. But he can differentiate when this, let's say, after the vascular occlusion test, it is pathological response that this flow does not recover when it's related to regulatory signal, vasomotion, flow motion, etc. And you can see in this thermal decomposition of the signal, he has already found in which case the endothelium signals can be guilty of this neurogenic response or myogenic responses with very sophisticated studies of this. And of course, the signal is very different in healthy volunteers, in septic shock survivors, and in septic shock non-survivors. So it appears that the loss of microvascular reactivity is key, and we will submit a paper soon about this 85 patients in whom it was done. And also, this is my team here, local team at the university, the dream team, I say, where they have been working in the black box here, trying to find if there is some let's say, some feature of the capillary refill time response that represent venous congestion, which would be very nice, no? And they are working on this. Also, there was this Chinese study where Huang et al., they showed there is a nice correlation. I mean, not too good, but there is a correlation between microcirculation and the tongue and capillary refill time. The issue here is that the video microscopy cost more than 20,000 euros compared to zero with the capillary refill time. Also, this is very interesting by Matthias Jacquet-Lagris from Lyon, where he subjected the cohort of patients to a passive leg rising, and he showed that even in 3 minutes, very rapidly, in patients that respond, that probably are coupled between the macro and the microcirculation, capillary refill time rapidly normalized, and this is later he administered a volume load, and he showed the same response. So, I mean, you can disclose the status of the macro-microcirculatory coupling with these simple maneuvers. And this has very relevant. It has to do with what we published in this article some years ago in 2016, if I remember well, where we showed that there are two phases in septic shock. An early one where humoral mediators produce a vasodilation at the arterial side and the venous side, and they decrease perfusion, the MAP, and also cardiac output. And then if you push fluids or vasopressor and you restore macro-hemodynamic, you rapidly restore the microcirculatory flow and normalization of capillary refill time, etc., because the microcirculation is not inflamed, it's dry. Compared to late stages of septic shock, when there is a progressive microvascular endothelial inflammation, and then there is a uncoupling of microcirculation, there is a plugging of leukocytes, platelets in the microcirculation, sticky red blood cells, a leak where fluids get into the interstitium and the microcirculatory units collapse. And this is edema, congestion, and in this late stage, this uncoupling lets that if you try to increase cardiac output, as you did in earlier phases, you will, with fluids or whatever, you can only worsen things. And in this late stage, you have to think other solutions. This is what we call the hemodynamic coherence or loss of hemodynamic coherence, or I prefer to name it macro to microcirculatory coupling. Maybe we saw this, we hypothesized some time ago, and now I think we demonstrated this, that if you perform a short acute hemodynamic test with fluids or increasing MAP, you can disclose the status of the macro-micro coupling with a short maneuver. And this is what we did in this study that we already published, physiological study, where we took patients with abnormal capillary refill time, and then apply the fluid responsiveness test. If it was positive, we administer the fluid challenge with 4 ml per kilo and monitored CRT. And in patients that were fluid unresponsive, we perform a hemodynamic coherence pressure test where we increase pressure to 80-85, and then we evaluated the restoration or not of flow. And this is what's published here, some results of these studies, where you see that with the fluid challenge, you get in 30 minutes a rapid normalization. This we went for normalization of capillary refill time, and then a decrease in more than 1 second in capillary refill time, and with the vasopressor test in patients that were fluid unresponsive, the response was not quite nice, because it was worrisome, because you see many patients tended to normalize capillary refill time when they had persistent abnormal CRT and were fluid unresponsive, getting a MAP challenge to 80-85 for 1 hour and looking at the results. But 4 patients here deteriorated capillary refill time, meaning that with this test you can disclose patients that will benefit from increasing MAP or not. That's not just taking into account if they were previously hypertensive or not. And this is probably a much better way to assess this, which is the best MAP for the patient, than the classic RCT where you flip a coin and then you say this patient go for a high target, this patient for low target MAP, and then you look at 28-day mortality, whatever. But this does not individualize treatment, and probably in both groups there were patients benefited and patients that were injured by these different MAP targets. So this is not the response. This is not the response. So, but Arnaldo Dubin from Argentina, in 2009 actually, he subjected a cohort of 20 patients, a physiological study, where in patients with abnormal, let's say, patient in whom he was assessing microcirculation at the tongue, and he increased MAP from 65, 75, and then to 85. And you see some patients improved. This is the microvascular flow index of the under the tongue, microcirculation here. They improved with this MAP rise instead compared to other patients who deteriorated the flow. This is interesting. The same was we found many years later in 2024 when we published this article, what we call now the vasopressor test, which we applied first in the Andromeda 1 study and later in the Andromeda Shock 2 study. And how can you explain this? Because in this interplay, there is of course, a patient cannot eventually recover we go to this one, recover capillary refill time, even if you apply, let's say, a fluid challenge or a MAP challenge, you manipulate the macro-hemodynamic domain. We saw until recently that if patient that did not improve capillary refill time, this was because of Juan Caninche's sepsis-related microcirculatory dysfunction. But we now know that there are other possible explanations, essentially an imbalance in this response, meaning that some patients improve MAP, but they decrease the pressure at the entrance of the microcirculation, the precapillary sphincter, as we call it before, and now they speak about this old, very difficult to measure critical closing pressure, the waterfall, which is somehow the driving pressure inside the microcirculation, and the venous side represented by the mean systemic filling pressure. So this is the macro-hemodynamic that we cannot assess easily, except under research context. But this can sometimes you increase MAP, you improve this, sometimes you deteriorate without knowing, and this can explain this. But also there is a role for no reperfusion of venous congestion. Of course, when you treat venous congestion, you may improve, which is the outflow pressure here. You can improve microcirculatory flow, and of course also the microvascular reactivity, as I spoke earlier, which is very important as we have been working with laser Doppler, etc. So finally, considering all of this, we came up with this. In abnormal CRT, we assess test this is a very nice review also. So I recommend it. It's free in Annals of Intensive Care. Fluid responsiveness. In those positive, we perform a fluid challenge in 10-15 minutes. And then if CRT improves, you are done. You're covered. But if the fluid responsiveness is negative, you go for a MAP challenge for 1 hour. CRT improves, you are done. But if the CRT does not respond, then you have a problem of macro-microcirculatory uncoupling. And there are many possible explanations which are difficult to assess, difficult to treat, etc., related to inflammation, to the play between micro-hemodynamics, etc. Very difficult to modify. But there is a variable here, venous congestion. You have to go to assess venous congestion because if patient is congested with Bexus or whatever, then you have to treat this and maybe you get reperfusion. This is there are studies underway with this. And these are the principles that we applied in the Andromeda shock study. We incorporated to personalize resuscitation CRT as a target, the same as Andromeda 1. We incorporated clinical hemodynamic phenotyping, considering pulse pressure and as a representative of stroke volume, and diastolic blood pressure. Instead of going to all patients for fluids, we decided according to this systematic assessment of fluid responsiveness. I had no time to get deeper into this, but it's very important, and selective critical care echo at some point. This is the algorithm. In patient with abnormal CRT at baseline, we assess pulse pressure. If it's normal, we do nothing. Periodic monitoring during the 6 hours intervention. If the pulse pressure is less than 40, representing a low stroke volume, we assess fluid responsiveness. And then up to 1 liter in 2 fluid challenges. If still abnormal, we go to tier 2. On the other side, if the patient has a normal pulse pressure, let's say, we assess diastolic blood pressure and try to improve that one. If it normalize, we stop periodic monitor. If not, we go to the other side. In tier 2, briefly, we perform an obligatory echo in this transition because we want to correct severe cardiac dysfunction at this point. And if not present, you go for fluid responsive, and then the same as in Andromeda 1, a MAP test or the vitamin test. Here, the first pillar, of course, then is to use capillary refill time as a target. You see with iterative assessment in different parts of the algorithm, if the CRT is normalized or is normal at baseline, you do no further intervention. You identify individual hemodynamic patterns here, the pulse pressure representing stroke volume and the diastolic pressure representing vasoplasia, and you act accordingly. And bedside echocardiography if it doesn't respond, and you go for systematic assessment of fluid responding before each fluid challenge to not give fluids in patients who are already fluid unresponsive, which in Andromeda 1 were 25% of the patients at baseline. And the acute hemodynamic test, we use the mean arterial pressure test, as I said before, in patients that did not respond to previous challenges and that were chronic hypertensive, or finally the dobutamine test to improve flow. In this study, the patients were comparable at baseline. They were recruited 2 hours after meeting septic shock criteria, the sepsis 3. They had received identical fluid loading before the study, identical MAP, identical lactate, capillary refill time, etc., etc. And we use a hierarchical composite outcome that include mortality, duration of organ dysfunction, organ support, which are the 2 most important outcome variables in critical care in the ICU during resuscitation: mortality and duration of organ support. And the third one, which is more epidemiological one, which is the length of hospital stay. And we assess it in the hierarchical way, which is the win ratio. And you see it was a big win here of the intervention compared to usual care with a P0036. A long time since we did not have a positive study in septic shock resuscitation, maybe since Rivers. So these wins were mainly driven by less duration in vital support in the intervention group. This was similar, stronger the signal in patients with higher SOFA, higher lactate, and higher CRT. The most severely ill patient responded better to this intervention. And this was mainly driven essentially by a more faster response of perfusion. You see in the intervention group at baseline compared to 6 hours, CRT decreased from 4 to 2.8 compared to the control group where 4 to 3.4. So faster resolution of hypoperfusion, gentler, with less prone to over-resuscitation, gets better results. And the trajectories were very nice. 36% of the patients in the intervention group had normal CRT at baseline, received no further intervention, just periodic monitoring. At the end, tier 1, very simple intervention, as you see, 2/3 of the patients had normal CRT after tier 1. They survived mostly, I mean, there was huge difference in better survival in this patient, but 20% had to progress to tier 2, a little bit more complex intervention, not too much, but 85% had normal CRT at the end. So it is possible, we had less than 10% of 5, 7 of major deviation, ambulation. So this is really, the people liked it, and more than 85% of the patients, included from the 750 patients in the intervention group, had almost no violation. The resuscitation fluids were less in the intervention group. They received more dobutamine and norepinephrine for the test, less net fluid balance. They had the intervention had lower CVP at the end of 6 hours because probably less congestion. We will know this because we are analyzing the ancillary study of Vexus at 6 hours, and also less lactate. So among patients with early septic shock, a personalized hemodynamic resuscitation targeting capillary fill time was superior to usual care for the primary composite outcome driven by it. And this is, of course, the beauty of this resuscitation study. Thank you very much for your attention.
Thank you, Professor Hernandez, for the lovely talk. So insightful, the concept of capillary fill time and microcirculation, sir. So I request the audience, if they have any questions, please put your questions. So, sir, meanwhile, I'll just put up a couple of points for discussion. So, sir, septic shock, classically, one of the phenotypes has pounding extremities, high cardiac output, and warm extremities, which means there's an increased flow to the extremities. But on the other hand, most have an increased capillary refill time. So is this just a dissociation between macro-circulation or micro-circulation, or is there something more to this to understand it?
You mean patients that have a high cardiac output and a low or an abnormal capillary refill time?
Yes, sir. This is the classical presentation of septic shock. One of the phenotypes is high cardiac output and warm.
Yeah, of course. In patient, you remember that the study from Guéry and Antoine Villar-Baron some years ago about clusters, hemodynamic clusters of phenotypes with a transesophageal echocardiography, where he described in 360 patients 5 different phenotypes of cardiac, let's say, dysfunction. One was the hyperdynamic, vasoplegic, extremely hyperdynamic patients. These patients that usually can have empty hearts, these kissing ventricles, etc. This extremely hyperdynamic patient after initial fluid resuscitation are very sick also, and they represent 20% approximately of the septic shock patients in general. And of course, if you have a high cardiac output, you have normalized cardiac output, and even in patients with hyperdynamic circulation, higher than normal, if you do not reperfuse the territories, it means that there is dissociation between macro-hemodynamics and microcirculation, as I spoke for the last 15 minutes of my presentation. And this can be caused by several aspects, several factors, including, of course, the inflammation of the microcirculation, more severe endothelial inflammation, more severe septic shock, but also disequilibrium between the macro, let's say, for example, MAP versus the forces that in the precapillary setting, they push fluids to the microcirculation. This is the imbalance between macro and microcirculation, but also because of the loss of microvascular reactivity, venous congestion. There are many possible explanations, but we can, let's say, englobe this under the concept of macro, micro, and coupling. And this is the paradox, of course. I mean, you can have a cardiac output of 20 liters, but no reperfusion. But this is explained by peripheral pathophysiological things, as I said in my presentation, and not by a problem at the central level.
Thank you, sir, for the answer. Sir, then you also mentioned at some point there is a dissociation between macrocirculation and microcirculation. Right? You increase the macrocirculatory flow, but the microcirculatory flow may not improve, CRT may not improve. So at what point in septic shock does this occur, sir? Initially, they are associated, right? You increase the macrocirculatory flow, the microcirculatory flow will increase, CRT will improve. But at some point, there is a dissociation. So do we have a particular stage where this happens?
We have, sorry, the last part. I didn't hear the last part.
The dissociation between macrocirculatory and microcirculatory flow. At what point does this occur? Because initially there is a
yeah. I understand. No. I mean, the problem here is that when, for example, imagine this: patients arrive to the emergency department, okay, and they are diagnosed as a sepsis-related, let's say, acute circulatory dysfunction. And then you start resuscitation, and you may fulfill or not the sepsis 3 definition yet, because you have not received at the beginning, of course, very early, the fluids, or not epinephrine, you have not assessed lactate, etc. Some patients arrive to the emergency department with early septic shock, just started a couple of hours ago, perforated gallbladder or whatever, appendicitis, etc., whatever. And these patients are still in the humoral phase, the early phase. They have a collapse, let's say, of blood pressure and of preload because of venous vasodilation for this circulation of inflammatory mediators. I call this the humoral phase. But the microcirculation is healthy, is still not affected. It's only dry because of the loss of flow. So in this stage, you keep fluid, you increase blood pressure with vasopressor, early vasopressor, and you restore microcirculatory perfusion. But some patients arrive with an already more severe disease with endothelial inflammation and severe collapse of the microcirculation, real chant, etc. This patient, when they arrive at the emergency department, they look similar. Sometimes they have lactate, similar hypotension, similar mottling, etc. But some of them are early in the process, and others are late. The only way to know if they are in this early phase where you rapidly restore macro-hemodynamics, and with this you restore peripheral flow, is to give a challenge of fluids, vasopressor, etc. If the patient is in late stage, he will not respond, and you make things worse. So this is very important to keep in mind. Patients arrive to the emergency department early or late in the process. It has nothing to do with what Rivers called the early goal-directed therapy. Early since hospital admission, therapeutic, but they arrive early or late in the process. So it's not about what you say, for example, oh, it has been 6 hours and then his patient does not. No. Some patients do not respond from the first minute. The only way to be sure that the patient is in this stage where the microcirculation is really shunted is to give a challenge. Increase pressure and look what happens. Increase cardiac output with fluids if the patient is fluid responding, and see what happens. And if patient recovers perfusion or capillary refill time does not normalize but tends to improve, then you are in the right track. You have to continue with this. Otherwise, if the patient has no response, then probably the problem is much critical. And then you have to think that the patient has a high chance to evolve into refractory septic shock, and you can know this with very acute hemodynamic tests and assessing the response of capillary fill time to this test. I think this is the future.
Thank you, sir. So then the patient is in septic shock and you are resuscitating him and he's on vasopressors, echo is done, echo is normal and the capillary refill time is normal, but blood pressure is not normal. So here do we try and improve the blood pressure, or if the capillary refill time is normal, we leave the blood pressure where it is?
I mean, if you are under vasopressors, your goal is to get an initial blood pressure. This is the consensus, I think, of 60, 65. Okay, we are all agree with this. An initial map. If you, with your initial intervention, just say fluids or vasopressors, early norepinephrine, you do not get a minimal map of 65 or 60, 65, you have 50, you may be in refractory shock, and this is another population. Okay? You have to get a minimal map with vasopressors. The minimal map is 60, 65, based on the physiological concepts of autoregulation, blah, blah, blah. If you have 60, 65, and you witness a reperfusion where capillary fill time normalizes, you are done. You don't need to push higher maps. This would be a severe mistake. You maintain there. But if you get no reperfusion, the CRT is persistently abnormal, you may test a higher map target to 80-85 for 1 hour and assess the response. The response, you maintain this higher map call. Otherwise, you return to 60-65. But under all precepts, you need this minimal map. Of course, there are many young people here, and I guess it's that there may be exceptional young patients with a healthy cardiovascular system and arteries, where eventually 50 of MAP may be enough to have a reperfusion. But these are exceptions, are in the one side of the Gauss curve, And of course, in this patient, you may speculate maybe he's very young, he can tolerate 55. Yeah, it's true. But speaking for the broad audience, I think you have to maintain in your mind 60, 65.
Thank you, sir. So then just the last couple of points. So you showed some slides on the effect of vasopressors, norepinephrine on microcirculatory flow. And it has a variable effect on microcirculatory flow. But all the time, one of the basic tenets of resuscitation is to give vasopressors, especially norepinephrine. So how do we align this, sir? The use of norepinephrine, increasing MAP, but norepinephrine having a variable effect on microcirculatory flow.
I'm not sure if I understood the question well, but we always our initial vasopressor is norepinephrine. Okay, and what we do in our practice is not a uniform practice across the 80-something centers that participated in Andromeda 2 or in Pegasus, which we have not published. We are analyzing the result. But there's some point where we add vasopressin. This is variable. We have now very strong data that support to use vasopressin in some given context related to the norepinephrine dose, etc. Has been quite variable. Patients that start at 0.2, some patients start at 0.5, etc. There is quite variable thing, but irrespective of that, I mean, if you want to read how we proceeded in the Andromeda 2 study, you can read the protocol paper, which is in the supplemental one, where we explain in detail how we performed this vasopressor test, patients that were already with vasopressin, others with norepinephrine, etc. We had some safety rules For example, if we had the norepinephrine higher than that, etc., or if we increase norepinephrine and the patient developed tachycardia, ST abnormalities, whatever, we stopped. So you have to, when you want to perform a vasopressor test, either with vasopressin or added to norepinephrine or with norepinephrine alone, we had both situations in Andromeda 2. You have to be very careful in looking at possible adverse effects, and then you stop.
Thank you, sir. Thank you. Final point, sir, about the measurement of CRT. Are you happy with the way we are doing it, or is there going to be a more objective and a more precise way in the coming future?
I am, let's say that, how can I say it? I think that with the way we assess capillary refill time in a standardized way, as I showed in my presentation, with the robust epidemiological data for more and more studies in the pre-hospital arena, in the ambulances, in cardiogenic shock, in obstetrics, in many fields now, in trauma, the relevance of the as a prognostic signal of capillary refill time, measured the way we do, and also, as I showed, the profound and deep physiology behind capillary refill time. It's not only just I press the finger. No. It's a vascular occlusion test that represents the function of the endothelium, the flow, the microcirculation. It is a very strong and nice signal. And now we have two big RCTs with the sum of almost 2,000 patients that targeted CRT and that showed a strong, let's say, impact in in major outcomes. And so when I ask myself, do we need then more technologically accurate ways to assess? We have a laser Doppler. We have a sublingual microcirculatory video microscope. Each one costs 20,000 euros. We have them in our lab. We have been doing studies with this to understand the physiological basis of this. But I hope, I would say, I will pray that some industries that are trying to design and test devices to assess in an expensive way, the same as we do in a simple way, and with a strong physiological, epidemiological RCTs supporting, just for the more precise measurement. I hope they fail. I hope they fall into bankruptcy because we are fed up with the industry and people thinking that the more they invest in technological devices, they will improve care. No. The Andromeda have been a nice example that you can do very important things with simple tools. So I hope that this never comes to a practice, because I will never buy. I will boycott this kind of device.
Great, sir. Thank you, Professor Hernandez, sir. Thank you very much for this wonderful talk. It was an honor, and we are really grateful. And I thank the audience that enjoyed it. And soon we shall put up the recording on our YouTube channel. Thank you, sir.
Thank you very much. Bye-bye.
Bye-bye. Good night, sir.